But tonight, in continuing our endocrine series, we're going to talk about pituitary diseases. We've talked about bone disease. We have talked about bone metabolism. We've talked about thyroid conditions. Now we go to pituitary diseases. And I just want to give the students a relatively broad sort of perspective on this part of the body, which is the president or commander-in-chief of the body and drives the function of all the glands, and basically is the manageable component of the head of the chain of the endocrinological mechanisms in the body. The pituitary gland. In this slide, you see a sagittal section showing the hypothalamus here. You can see the proximity of the pituitary gland to the optic apparatus, the optic chiasm lying immediately above the anterior pituitary. This bony cavity within which the pituitary gland sits is called the sella. We know that the pituitary gland has an anterior lobe and a posterior lobe, and they are connected through the pituitary stalk to the hypothalamus. The hypothalamus has all the hypothalamic nuclei that drive the function of the pituitary gland, either by direct neural circuit to the posterior pituitary, for example, dopamine secretion, which is inhibitory to prolactin secretion at the back, and of course, the hormones that are secreted into this portal system that drives the anterior pituitary lobe to make things like growth hormone, make things like ACTH and so on. And we'll just talk about these things as we go along, talking about our clinical conditions. Just a reminder that the anterior pituitary releases thyroid stimulating hormone that makes your thyroid gland produce T4 and T3. It makes ACTH that drives your adrenal gland to make cortisol. It creates hormones that, like prolactin, that creates leads the breast secreting milk. It makes growth hormone, which leads to secretion of IGF in the liver. So liver is a gland as well as being the center of detoxification. It makes your gonads produce appropriate hormones in males and females, testosterone, estrogen, progesterone. And then the posterior pituitary secretes antidiuretic hormone and oxytocin. And so these hormones can get affected by pituitary diseases. I just want to talk about classification of pituitary. These are the common conditions that affect pituitary glands. So we can have tumors arising in the pituitary gland, and there are generally two common types of tumors that occur in the pituitary gland: pituitary adenomas. Vastly the most common type of tumor that affects pituitary glands are adenomas. And then there is another type of tumor called craniopharyngioma. And the craniopharyngioma is a lesion that arises somewhere between the third ventricle, hypothalamus, and can grow towards the pituitary gland. It's really a brain tumor that occurs in the region of the pituitary tumor. It's a pediatric tumor, but can also occur in adults. And we have also this entity, which is a cystic lesion called Rathke's cleft cyst, which is epidemiologically relevant because as the anterior and posterior pituitary come to meet each other, there is a little bit of the Rathke's pouch, which is for the lack of a better word, a bit of tissue from the back of the pharynx that comes and gets entrapped between the evolving anterior and posterior pituitary, and sometimes it can create a benign cyst, and we see it very commonly in neurosurgical practice. It's not a particularly dangerous entity, but it can become very large and compress the optic apparatus and cause visual impairment. Also, we have inflammation, which can occur in the pituitary gland, hypophysitis, a condition that is accompanied sometimes by headache, and a vast range of possible derangements that can affect endocrine function. Infection and metastatic disease are rare in this region. I guess you can have infections spreading from the skull base to that region, but it's rare to have infection occurring in the pituitary gland per se. Post-operative infection is probably more common. So in general, how do we assess pituitary function? I briefly mentioned these, and then I'll go through their relevance and elaborate on the subject more as we present some cases. So every patient with a possible pituitary lesion would benefit from a full blood count because, for example, a person with Cushing's disease can have anemia of chronic disease. Electrolytes are very relevant because you can have problems with electrolytes. Sodium fluctuations are very common in patients with pituitary dysfunction. You can have diabetes insipidus or syndrome of inappropriate ADH that can result in swings or decreases or increases in sodium and osmolality. And relevant and alongside EUCs, we have urine osmolality and electrolytes. Patients with certain forms of pituitary tumors, particularly Cushing's and acromegaly, can develop diabetes. So assessment of glucose level is part of your assessment of the pituitary function. An oral glucose tolerance test is relevant to the diagnosis of diabetes, but it is also important component of assessing patients with acromegaly, because giving a person a dose of glucose should suppress their growth hormone. And so we use an oral glucose tolerance test, for example, when we have removed a pituitary tumor causing acromegaly, to see if they've had surgical cure from their disease. An endocrine panel, whenever we see a person with a pituitary tumor, we perform these tests relevant to pituitary and the end organ endocrine function. So ACTH, produced by the anterior pituitary, leads to secretion of cortisol by the adrenal cortex. LH and FSH, secreted by the pituitary, leads to the gonads secreting estrogen and testosterone. TSH, secreted by the pituitary, lead to the secretion of T3 and T4 by the thyroid. Growth hormone secreted by the pituitary leads to the secretion of IGF-1 by the liver, and prolactin, which is tested for lesions called prolactinomas, which secrete prolactin. And then we talk about a bit more specifically about low dose and high dose dexamethasone suppression test, inferior petrosal venous sinus sampling. And sometimes also as part of our assessments, we have to do scans of the abdomen, for example, to look for lesions in the adrenal gland and so forth, and thyroid scans and so forth, when we are suspecting whether the problem is arising from the pituitary or from the thyroid itself, for example. Doing MRI scans on the pituitary are a critical component of assessing patients with pituitary lesions. An MRI of the brain itself doesn't show a pituitary lesion very well. So if you're suspecting that someone has a pituitary tumor, you have to ask specifically for an MRI of the pituitary gland. Often we need to use contrast enhancement, and what we usually find, and I think I need to point out that the brain has this thing called the blood-brain barrier, which prevents contrast, the gadolinium contrast, which is used in MRI assessments, is not taken up by normal brain tissue because of the presence of the blood-brain barrier. But in the brain, there are a few sites that enhance. So the blood-brain barrier is broken in certain regions, most of their names start with P. For example, the pineal gland doesn't have a blood-brain barrier. The pituitary gland doesn't have a blood-brain barrier. The area postrema, which is in the brainstem, and that's the area that senses the presence of toxins in the blood, doesn't have a blood-brain barrier. Those regions enhance with contrast injection. And so if you see a picture like this where there is enhancement, and then there is an area where there is no enhancement after administration of gadolinium, that area is more likely to represent your tumor. So you see here is a T1 weighted MRI scan of the brain where everything is dark, the CSF is dark, the vascular structures are dark, and then they give the contrast, and then they take a series of images. Sometimes you can have just one image taken, sometimes you can take a series of images after a few minutes. This is a more dynamic study, and you see the pituitary gland itself over here, quickly taking up the dye because there's no blood-brain barrier, the tumor being more necrotic and less vascularized, taking less or later. And so in this image, which is the same picture, that's the coronal image through the pituitary, that's a sagittal sideways image through the pituitary. You can see the pituitary gland here at the back, the pituitary stalk, and the tumor not taking the contrast as early as and as intensely. And there it is clearly shown as a lesion that does not enhance with contrast. I hope that in the future I can have a session to talk about brain radiology and we can go through these things in more detail. Remember, this is a T1 weighted image. In T1 weighted MRI sequences, CSF is dark. In T2 weighted images, CSF is intense or white. And just as a reminder, the terminology that applies to different radiological modalities as to how dark or white things are different for CT scan and for MRI. For CT and X-ray, we use the word opacity, density or opacity. For MRI, we use the word signal intensity because we're dealing with magnetic resonance. So we talked about these things now. We said that the most common pathology that we deal with in pituitary, in cellular and pituitary pathology is pituitary adenoma. And a pituitary adenoma can be classified according to its size. A small lesion is a microadenoma, less than 1 centimeter. A larger lesion, more than 1 centimeter, is often referred to as a macroadenoma, disregarding whether it's secreting hormones or not. But we can classify tumors also according to their endocrinological function. So a pituitary tumor, micro or macroadenoma, can be non-functioning or functioning. And the most common functioning tumors either secrete prolactin or ACTH, which leads to elevated cortisol levels, hence causing Cushing's disease, or secrete growth hormone, causing acromegaly in postpubertal individuals or gigantism in prepubertal individuals. So these are the endocrinopathies that you can get from a functioning pituitary adenoma. Thyroid stimulating hormone secreting tumors, LH or FSH secreting tumors, are exceptionally rare. I'm a neurosurgeon with 25 years of work in neurosurgery and pituitary surgery. As yet, I have to see one of those tumors. Prolactin, plenty. ACTH, plenty. Growth hormone, plenty. And non-functioning. Lots and lots of non-functioning tumors. And these non-functioning tumors come to our attention because they get bigger, because they're not causing an endocrinological problem. So they tend to more frequently present as a macroadenoma and become clinically apparent because of their size. We also classify pituitary tumors dependent on their patterns of growth. Are they growing up towards the optic chiasm? Are they causing visual disturbance? Are they growing sideways towards the cavernous sinus? Are they growing just within the cella? So what are the effects of a pituitary tumor? Through this evening's talk, we will see some clinical cases and we will elaborate on that, but a large tumor that is growing upwards from the cella towards the chiasm can cause compression of the optic apparatus. Optic chiasm is often directly compressed, and compression of the chiasm can cause loss of the temporal aspects of the visual field. So a narrowing of the field of vision is described as a bitemporal hemianopia, is one of the common presenting features of pituitary tumors that are macroadenomas with suprasellar extension. Large non-functioning tumors can also cause impairment in pituitary function. They're not secreting anything, but they can compress the pituitary gland's functional parts and cause problems with ADH secretion. They can cause loss of steroid function, so loss of mineralocorticoid activity, diabetes insipidus. So what's diabetes insipidus? The condition where you're not producing ADH from your posterior pituitary. 2 weeks ago, some of the students that were with me saw a gentleman presenting with diabetes insipidus who basically noticed that when he went to work, he had to take several bottles of water with him, and he went to toilet every half an hour and urinated all of that out. So that is thirst and excessive urination. Hypothyroidism can result because of loss of thyroid function, hypogonadism, loss of libido, loss of the menses, and infertility. And in advanced cases, because of lack of growth hormone production, we can lose bone density. And many patients with pituitary tumors that have been unrecognized develop osteoporosis of quite severe extent, especially affecting the spine. Can you please close that door? Thanks. Now, as we said, secreting tumors can cause very well-defined clinical syndromes, such as Cushing's disease, growth hormone secretion from a microadenoma. So usually these tumors that secrete only one hormone. So growth hormone secreting tumor can cause giantism in kids and acromegaly in adults, and a prolactinoma can be also a syndrome that occurs from secretion of prolactin. Sometimes the tumors can be very large to the point that they obstruct CSF pathways, resulting in obstructive hydrocephalus, headache, and features of raised intracranial pressure. Rarely, a pituitary tumor can, if it's large enough, can bleed suddenly, and the bleed from a pituitary tumor presents with all of these things all at once: loss of mineralocorticoid function, sudden loss of volume, shock from severe urination and loss of fluid, with the patient getting very, very sick and at the same time losing vision because of a hemorrhage in a tumor that has outgrown its blood supply, and that condition is referred to as pituitary apoplexy. For some reason, it is more common postnatally in women who've just given birth. Pituitary apoplexy in that context is referred to as Sheehan syndrome. So to exemplify these features, I'm presenting the case of a man, very sad story. This guy had a head injury 10 years ago, 10 years before presentation. He was 50 years of age. By the time he saw me, he had very, very poor vision. His doctor told him that his head injury 10 years before, when he was playing rugby, caused him to lose his vision. His doctor told him that he was losing his memory and cognition because he had that head injury 10 years ago during a rugby match. He was fatigued, he had no motivation, he didn't work very hard, he lost his business, he lost muscle mass, and unfortunately, he had lost his family, his wife, because of that. loss of libido, and he was in a bad place in his life. And I think a CT brain would have helped save this guy's life, business, vision much earlier in life. This was his tumor. You can see this extensive pituitary tumor. Again, this is an MRI, a sagittal view, a midsection through the brain with this lesion that's showing extensive suprasellar extension, compressing the visual apparatus somewhere up there. It's the chiasm and optic nerves are pushed all the way up. There is obstruction of cerebrospinal fluid flow, and he had some degree of hydrocephalus. This is a very large tumor coming all the way into the third ventricle. That's the brainstem, that's midbrain there. That's the pons here. That's the basilar artery coming up here. And the compression of all of these structures made the surgery obviously relatively difficult. But I like to point out to you that as part of his assessment, he had this study, which is a visual field perimetry. If you're ever concerned about someone having some partial visual loss, you can send them for assessing their acuity by an optometrist, and optometrists can perform perimetry where they send little light signals, and the person can pick up the signals. And if they're missing out a lot of signals coming from there and there, they have obviously a bitemporal visual field deficit. So this patient had very complete loss of the temporal fields. Just to remind you, when you're studying for your neuroanatomy pathways and relevant to the perimetry assessment, these are the types of field deficits that you can see when you perform field assessment. And each one of these patterns of visual field loss, and they're everywhere, you can find this picture anywhere online, it shows you what location in the visual pathways the person has developed the impairment. With pituitary lesions, you are losing the information coming from the nasal field of each eye. And of course, the nasal part of the retina of each eye picks up the temporal aspects of the visual information. You can have lesions in the optic tracts, and in the optic tract, of course, you have here the optic nerve, the optic chiasm, the optic tract. Then you have here the medial geniculate body in your thalamus. And from there, the visual information is relayed through optic radiations that go through the parietal and temporal lobes to the visual cortex. And so if someone has a temporal lobe tumor on the right side, they will have loss of vision in the upper outer quadrant. If someone has a parietal lobe lesion, it can interfere with the lower quadrant of on the same side of as contralateral to the lesion. So if you have a right-sided cortical lesion here, you will have a left-sided homonymous hemianopia. If you have a right-sided temporal lobe lesion, you will have a left-sided superior quadrant tanopia. And if you have a parietal lobe lesion, you will have an inferior quadrant lobes, contralateral to the side of the lesion. It's always contralateral to the side of the lesion from the optic nerve to the cortex, contralateral to the side of the lesion. And there are more subtle patterns of visual loss that you see in this diagram. But remember, with a pituitary tumor, that's the pattern of visual loss. The two temporal aspects of vision go. Often it starts from the upper aspect going down. So that patient had a pituitary, a resection of his pituitary tumor. Part of his visual field deficit remained, unfortunately, because it was detected too late, but he made a reasonable recovery. And most importantly, replacement of his endocrinological dysfunction, his hypogonadism, his cortisol deficiency, and his thyroid deficiency that were resulting from that large mass occupying lesion allowed him to regain function and resume his life with much better quality. This is a 42-year-old man now I'm going to talk about. A 45-year-old man, sorry. He's 45-year-old man. He looks kind of like this. He's got pimples. He is right-handed. He's presenting with tiredness and lacking in energy. He's finding that he goes to the toilet frequently at night. He has got some back pain, which is aggravated by physical activities, for which he takes some medications. And there is some family history here. From his appearance, does anyone want to make a guess as to what condition he is affected by? And let's talk about some possible causes for his presentation here. I would invite anyone from the audience to make a diagnosis.
I was going to comment on Cushing's syndrome, but also hypothyroidism could be one thing as well because of the lack of energy as well. But from his face and the moon face and all that, it seems to be like Cushing's syndrome.
Who is that, sorry?
Hannah.
Hannah, yes. I think that's pretty good guess. I think tiredness can be a very general complaint in patients. There is textbooks upon textbooks that you can write about the possible causes of tiredness, but Cushing's disease itself can indirectly cause tiredness because you can have a chronic form of normocytic anemia. You can have diabetes mellitus as a complication of Cushing's, and I guess that might be why he's urinating frequently at night, because patients with Cushing's are at increased risk of all sorts of other metabolic derangements. Does anyone want to make a comment about the possibility of his back pain? Why would a Cushing's patient have back pain? What did we say earlier about the pod? We'll show you some x-rays. You will see.
Can I just say, this is Mikey here. The back pain could be perhaps due to muscle wastage, and then maybe accumulation of fat in the back area, in the upper, in the central part.
There's a thing called buffalo hump, and I'll show you pictures of that. Yes. Buffalo hump. Yeah. People with increased cortisol levels, even people that have chronic increased levels of cortisol due to stress, sometimes get a buffalo's hump. It's interesting, slightly sort of, I guess, high in the normal range, cortisol levels can give many people a buffalo hump. So you see that in elderly patients that are just post-menopausal, it's very frequent. But don't ever forget the possibility of osteoporosis in everyone who has some form of endocrinopathy. Bones seem to be an easy target. So that's the buffalo's hump in this patient. He has these striae, of course. These are just pictures from some of my patients. On examination, he has a normal pulse rate. He's got an elevated blood pressure. So these are features that you have in patients with Cushing's disease. Hypertension. His abdomen was non-tender, but he had this on inspection of his abdomen. His peripheral pulses were normal, but what we found of interest was this compression fracture of one of the thoracic vertebrae. You see the rectangular structure of these vertebrae here, 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 but that one is slightly wedged due to a fracture. So osteoporotic fracture is a possible cause, usually in the thoracic spine, is a possible cause of back pain in a patient with Cushing's disease. It's a horrible disease. Cushing's disease, untreated, can kill within 4 to 5 years generously. So be very mindful that this is a dangerous problem that needs to be eradicated. It doesn't have mercy on its victims. This is the blood results from the same patient. You see mild derangement in the LFTs. Electrolytes are normal. He has risk factors for cardiovascular disease, independent of his Cushing's disease. And this is his plasma glucose level, which is already in keeping. A random glucose of fasting glucose of 8.2. That's in keeping with diagnosis of diabetes mellitus. So he's already developed the diabetes, which is a complication of his Cushing's disease. Are you all comfortable with the interpretation of these results, I hope? Please say yes. His ESR is normal, and this is his bone density. Now, there are two different ways of measuring bone density: the DEXA scan, which I'm sure Professor Diamond talked about in his earlier presentation, and QCT. QCT allows you to measure bone density in a specific bone right in the area that you are interested in, whereas DEXA scan looks at the spine, distal radius, and the head of the neck of the femur, which are the common areas that elderly with osteoporosis tend to develop their fractures. You can see that he's got significant spinal osteoporosis and some degree of osteoporosis in his Wardman's triangle. Now, we need to, a patient has Cushing's syndrome, is a patient who has got elevated cortisol levels, but we don't know if the patient has actually got Cushing's disease, which is a Cushing syndrome that's driven by an adenoma in the pituitary gland. So we need to establish that, because the treatment is surgical, and we need to remove that adenoma if the person has Cushing's disease. But we need to do the right investigations to establish as to whether or not the patient has Cushing's disease. So we do the serum urine electrolytes, osmolarity, we do ultrasound, look at the kidneys and the adrenal glands to look for adrenal tumors that can produce cortisol. Patient has hypertension, we need to look at this patient has hypertension, we need to perform a renin-angiotensin-aldosterone assessment independently for their hypertension, and the assessment of the kidneys also helps us in establishing and excluding other causes of secondary hypertension, such as renal artery stenosis. And we again talk about the endocrine panel, and we see that in his results, he's got a very elevated cortisol level. So that's the normal range, and his cortisol level is 1010. He's normal in respect to his testosterone levels. His thyroid functions are within normal range. He does not have elevations in his other hormones, but his ACTH is elevated. So where should we go from here? If the patient has elevated cortisol, his clinical presentation is with Cushing's disease, and he has got an elevated ACTH. So we can kind of tell that ACTH is making his adrenal glands make cortisol. But how can we be sure that the ACTH, sorry, that should be ACTH here, not ACT. How can we be sure that the ACTH is coming from the pituitary gland? Do we know, does anyone know whether there is other sources that can lead to elevation of ACTH other than pituitary adenomas? Any of the students? No.
Are you talking about, Dr. Ali, are you talking about the tumors causing ACTH to rise, and that's why you do like a suppression test to try and see if it's coming
So
from
what other tumor can cause elevation in ACTH other than a pituitary tumor that's secreting ACTH?
Yes.
What else can?
In the lungs, you can have lung cancers that could potentially do that.
Paraneoplastic, that's correct. So it's a paraneoplastic condition commonly related to small cell lung cancer, correct? And one of the interesting clinical, is there anything clinical that you can do to detect whether or not this is related to a paraneoplastic lesion, other than dexamethasone suppression test? What happens in those patients who have a lung cancer secreting ACTH? They get extensor pigmentation. They develop pigmentation over their elbows here. Why? Because their ACTH has some melanotrophic effect, whereas the normal ACTH that comes from the pituitary doesn't. So you look at their extensor surfaces over their knees and elbows to see if they're dark and hyperpigmented. Just an interesting little point. So we do a low dose, to establish the diagnosis of Cushing's. I guess we already know in this patient. We can also do a 24-hour cortisol sampling. We do a low dose dexamethasone suppression test. We just give them 1 milligram of dexamethasone. And if their ACTH goes down, it's not, the ACTH is not coming from the cortisol elevation, is from the adrenal gland. Then we do a high dose dexamethasone suppression test to see if it is the pituitary that's creating the ACTH, or if it is coming from ectopic sources such as small cell lung cancer. A high dose dexamethasone suppression test suppresses the pituitary driven ACTH, but it does not suppress a lung cancer creating ACTH. And that's how we tell the difference. Sometimes we've done an MRI of the brain and we've already seen that the patient has a microadenoma or a macroadenoma in their pituitary gland, and that makes the diagnosis very easy. But there are cases where we actually can't see the tumor. So we've done an MRI, we've done the high dose dexamethasone suppression test, and the dexamethasone suppression test has led to decline in ACTH. So we are pretty sure that the ACTH that's driving their cortisol secretion is coming from the pituitary gland. But we can't see the tumor on their MRI. So how can we go and be sure to go and remove this person's pituitary gland, not seeing the tumor? Well, there is a test. We do an inferior petrosal venous sampling. So we take a little bit of blood from the inferior jugular vein down here. It reads a certain ACTH. Then we go a little bit higher. We go a little bit higher and take samples through angiography. And if the concentration is ascending as we go up towards the pituitary gland, we know that it must be the pituitary gland that's secreting the ACTH. And even better, if the concentrations rise on one side and not the other side, we know it is the lesion is on the right side or the left side. So it helps us to lateralize the lesion, looking at the difference between the inferior petrosal venous sampling from one side to the other. It can help us confirm that there is a little microadenoma there, even though we can't see it on the MRI. By removing it, we can cure the patient. And we can also say that we can be a little bit more aggressive with our surgery on the right side or the left side. Does that make sense? Sure, you all say yes. So this is a microadenoma on the right, on the left side. You can see that lesion there. This is the pre-contrast MRI. That's the post-contrast MRI. Just like we said earlier, this is a T1 weighted MRI. This is a coronal sequence through the cella, and you see that the normal pituitary gland doesn't have a blood-brain barrier. It takes contrast. The tumor does not take contrast because it's not very vascular and it's largely necrotic, yet it manages to make the patient so sick. So we will go through the nose and remove that tumor and the patient will be fixed. So this is just a list of different types of tumors that can cause paraneoplastic raised ACTH. This diagram is for you to sit down and memorize the features of Cushing's disease, which we talked about, but we showed you some pictures of their striae. We talked about spinal fractures. We talked about the buffalo hump. In ladies, they can get increased facial hair, acne, loss of hair. They get these moon faces and truncal obesity, thinning of the skin, and easy fractures. And there are tremendous psychiatric and psychological problems that these patients can get intense depression and anxiety. They can get very much off the rail with their life due to the psychiatric aspects of their condition. Again, a feature of the striae in patients with Cushing's is that they're relatively purple as opposed to stretch marks from weight loss. So in managing patients with Cushing's disease, we have to be very active about managing their secondary complications, manage their sugar, like we do with all diabetic patients, manage their hypertension. Before we operate on their lesion, we need to stabilize them medically. And to stabilize them medically, we need to manage their diabetes, we need to manage their hypertension, we need to look after their bone density and treat their pains and aches and psychiatric problems and all of those things before we can make them ready for having their definitive treatment, which is their surgery. There is an anti-steroidogenesis enzyme, which is an antifungal agent, ketoconazole, and that has been used in treatment of patients with Cushing's disease. The aim of treatment, so that can bring the cortisol levels down. Ketoconazole can help a little bit in their stabilization. Surgery with complete resection of the tumor. We can't leave even a tiny molecule. We can't leave even a tiny cell of Cushing ACTH secreting tumor behind, because with surgery for Cushing's disease, as opposed to surgery for acromegaly, the treatment is very black and white. If we leave any tumor behind, they have not benefited from the surgery at all. That little bit of leftover tumor will continue to produce ACTH in large volumes and large quantities and lead to persistently elevated cortisol levels with ongoing damage. It's surgery is an all or none phenomenon. If the patient has had suboptimal resection and we can't remove the tumor completely, then the treatment will consist of radiotherapy. Nowadays, more radiosurgery, which with some latency, some years down the track after the treatment, it can reduce the secretion of ACTH. We talked about ketoconazole. And finally, somatostatin analogs can use to treat the patients with medication if they haven't responded to surgery or radiosurgery. That's another example of the buffalo hump that we talked about. That's a very extreme version, but you know, I see this all the time in people who have slightly elevated cortisol levels or so-called pseudo-Cushing's. Pseudo-Cushing's is when people, due to mental stress, due to poor sleep habits, develop some slight elevations in their cortisol levels without having an adrenal tumor, without having a pituitary lesion. And, you know, you can look at people's backs and see how stressed they are sometimes. You see this fat lump accumulation many times. So this is the next patient. It's pretty obvious. This is an acromegalic patient. And the features include usually enlargement of the hands, changes in facial features, enlargement of the jaw. Sometimes they develop loss of vision. With all pituitary tumors, if they're large enough, they can develop visual impairment or bitemporal hemianopia from mass effect from their pituitary gland. Remember, with all pituitary lesions, a lump that's secreting or non-secretory can compress other parts of the pituitary gland and make the patient deprived of all other normal hormones and make them hypogonadal or hypopit. But generally, an acromegalic person has difficulty with enlargement of their bony structures, feet, hands, and they struggle with developing terrible peripheral arthritis, terrible peripheral entrapment neuropathies. They obviously have cosmetic issues, pain, numbness, and medical complications not too dissimilar to what we see in Cushing's disease. Hypertension, diabetes mellitus, increased cerebrovascular and cardiac risk for myocardial infarction and stroke, and increase in the risk of developing certain forms of cancer, for example, bowel cancer. It's not clear that resection of the tumor will eliminate those risks in the long term, but certainly would be intuitive to think that there is potential for reduction in the risks. So again, we assess the patient with an MRI of the brain, skull base and pituitary with contrast enhancement. We perform that endocrine panel that I presented earlier. We have to be very careful to look at their growth hormone. Sometimes you see very subtle raises in growth hormone. IGF-1 is increased, and sometimes it's the reverse. But one of the most sensitive ways of assessing someone for acromegaly is to do an oral glucose tolerance test. In the presence of glucose, a normal person shouldn't produce growth hormone. The growth hormone should go right down. And so glucose tolerance test is not only used to diagnose the presence of diabetes, which is a complication of acromegaly, but it's also used to assess growth hormones appropriate secretion. And we use it in the post-operative setting to see if we have cured the patient or not. Treatment, again, acromegaly is treated with surgery. And removing the lesion can eliminate the patient's symptoms. We remove the lesion. The next day, the patient says that his voice is less rough, his facial contours are softer, and very quickly they start to improve in terms of their arthritic pain, diabetes, blood pressure, which are important things. Perhaps some of their cosmetic concerns are not things that they can recover from very quickly, but their blood pressure and diabetic issues, which are important risk factors for cerebrovascular and cardiovascular health, improve very quickly. If the tumor is not resectable completely, then radiosurgery is performed. And again, the effect of radiosurgery is unfortunately with some delay. So 2, 3, 4 years of delay in seeing a response. That's called the latency period. However, as opposed to Cushing's disease, where either you remove the tumor completely and they get cure, or if you haven't removed the tumor completely, there is no benefit from the surgery. Patients with acromegaly, even if you remove half of their tumor, they will benefit because their latency period to respond to radiosurgery improves. So if they were going to respond in 4 years, they respond in 2 years, and they become much more sensitive to somatostatin analogs such as octreotide if you have removed a significant part of the volume of theirs. The volumetric resection helps. The third clinical entity that is a secreting pituitary tumor is prolactinoma. This is the last one that secretes. It makes 1/3 of pituitary tumors, and it is the only pituitary tumor that's curable with medication. The medication is cabergoline, an inhibitor of prolactin secretion. Remember, this is an important thing that I want to say. Remember the panel that I told you at the beginning of the talk. So you check your ACTH, you check your cortisol, you check your TSH, you check your T3, T4, you check your LH, FSH, you check your estrogen and testosterone, you check your prolactin. Now, if a person has a non-secreting adenoma, does not secrete any growth hormone, does not secrete any ACTH, does not secrete any prolactin, this tumor can compress the stalk of the pituitary gland and prevent the inhibitory control that's coming from the hypothalamus to stop formation of prolactin by inhibiting the dopamine from reaching the posterior pituitary. It can give rise to an elevation in prolactin level. So upper limit of prolactin is about 400. Their prolactin will be 700 or 800. That's in keeping with a non-functioning pituitary macroadenoma that's pushing on the pituitary's stalk. People who have true prolactinomas, and this is such an important recognition because prolactinomas respond to medication. They dissolve away with medication. They don't need surgery. They don't need anything. You just give them cabergoline, which is a tablet you take twice a week, and your tumor will go, your symptoms will go, and you get fixed. But you need to diagnose it correctly, because if it is the stalk effect, you are fooling yourself. If the tumor is producing prolactin, a small tumor even makes the prolactin levels jump to 1,000, 2,000, 3,000, 10,000. So if someone's prolactin in the standard units that we use in Australia, with the limit being 300 to 400 being the upper limit of normal, if someone's prolactin is 700, 600, it's not a prolactin secreting tumor. It must be in the thousands for you to assume that it is. You can try the medication and see if it shrinks, but you have to monitor them very closely and see that the prolactin drops right off after a couple of weeks of giving them cabergoline. So be aware of the stalk effect. But what can a prolactin secreting tumor do to you? Well, patients with prolactinomas develop loss of libido, gynecomastia, and lactation in women who are not postnatal, lethargy, psychiatric impairment, depression, loss of motivation, irregular menstruation, loss of periods, and if unrecognized over a long period of time, osteoporosis. These are symptoms and signs of prolactinoma, and yet it is such a curable disease if it is recognized early and the patient receives cabergoline. So these are the endocrinopathies. And I think the first case that, so endocrinopathies that arise from pituitary tumors are acromegaly, gigantism, Cushing's disease, and prolactinoma. And the first case that I presented was, of course, a non-secreting large tumor, which by sheer mass effect on the optic chiasm and the CSF pathways was causing significant problems for the patients. I'm happy to answer any questions at this point. Thank you. You're all asleep.
So we're still here. Thank you very much.
Any questions? No? Very good.
Yeah.
Thank you, Professor Ghahreman. That was great. Thank you.
Bye. Bye.
Renato.
Bye.